Minute. Okay. Good morning, afternoon, evening, everyone, depending on where you are in the world. Welcome to part two of Digital Mental Health is Here, ensuring the quality of care, a global perspective. For those of you who don't know me, I'm Fiona Costello. I work with eMHIC and I'm honoured to be your host for today's webinar. This session is hosted in partnership with the Agency for Integrated Care in Singapore. In part one of this series, we explored perspectives from the Asia Pacific and Middle East. Some of you may have been able to join us for that. But today, we turn our attention to England, Scotland, and Singapore to discuss progress, challenges, and lessons learned as digital mental health becomes part of mainstream care. We'll explore how providers are supporting their workforce to embed digital tools in everyday practice, how regulators are adapting to new realities, and how technology itself is evolving. But as always, a few quick housekeeping notes before we begin. Feel free to share your current location or area of interest. To do so, you can click on the three dots next to your name tag, choose Edit, and add your country or area. This allows you to connect with others who share similar interests. If you have any questions for the panelists during the webinar, which I'm sure you will, please feel free to post them in the Q&A box. During the Q&A session, I will do my best to include as many of them as possible in our discussion. And lastly, today's webinar is being recorded, and the eMHIC team will soon share the recording in the Knowledge Bank. Now, it is my sincere pleasure to introduce our speakers. Their experience and work portfolios could easily fill the whole hour, so in the interest of time, I'll keep introductions brief. You can read more about them on the eMHIC webinar page. Dr. Daniel Thung, who won't be joining us in person, but who has pre-recorded a session for us, is a child and adolescent psychiatrist and CEO of Singapore's Institute of Mental Health. A global leader in health and telepsychiatry, he has authored over 200 publications and developed innovative solutions, including a patented ADHD treatment. He also serves as president of the International Association for Child and Adolescent Psychiatry and Allied Professions. Next, we have Dr. Christopher Shook, who is Chief and Senior Consultant in Forensic Psychiatry at Singapore's Institute of Mental Health and Director of the National Mindline 1771. A former Clinical Director of the National Addictions Management Service and Head of Psychological Medicine at Kutuk Puat, he also serves as a consultant to the Singapore Armed Forces and Civil Aviation Authority. With a distinguished military and clinical career, he has published 3 books and over 20 research papers on mental health. We then have another Chris. Chris Wright is a system designer and technologist with over 20 years' experience transforming digital mental health services in Scotland. As National Advisor for Digital Mental Health and Head of the Digital Mental Health Programme at Scottish Government, he leads national strategy and innovation to scale high-quality, sustainable digital solutions and drive cultural change across health and care. And last but by no means least, Holly Cool. Holly Cool is Senior Manager for Digital Mental Health at the MHRA, leading the Wellcome Funded project on the clinical evaluation and regulation of digital mental health technologies. With a background in psychiatric nursing and experience across multiple NHS mental health services, she combines clinical, regulatory, and lived experience perspectives to advance safe and effective innovation in digital mental health. So to give you a sense of how the session this morning, this afternoon, this evening is going to go, each of our speakers will take a couple of minutes to talk about their work, and then we'll go straight into a panel. So a warm welcome to you all. Thank you for joining us. Happy Friday. And Chris, I'll leave you to take it away with Daniel's pre-recorded session.
Thanks very much, Fiona. I will now play Prof. Daniel Thung's pre-recorded presentation.
Hello, I'm Dr. Daniel Thung from Singapore. I'd like to talk to you about eMHIC and digital adoption. My next speaker, Dr. Chris Shook, will explain to you a nationwide effort that we're trying to develop our tiered care model. The scope of digital mental health is very broad. And over the years, this is some of the domains of what I call e-health. Telemedicine, it could be mobile devices, it could be big data and how we integrate networks. In terms of the electronic health records and the electronic medical records, Singapore has gone to scale, which means that the entire country is going to one platform that is shared from whether it's primary care across what we call our tiered care model. At the same time, during the pandemic, digital mental health took off. And very much like what John Torres has predicted in his important paper describing digital mental health and the way you can scale in view of the crisis in terms of resources, services, and governance that we have, the gaps that the World Health Organization identified, from face-to-face interactions to asynchronous, data-driven, even artificial intelligence supported mental health ecosystem. Now in Singapore, and I think I dare say most of the world, regulation is strongest at the clinical side of the house. And all of what we describe in terms of digital health and digital mental health are within that treatment, diagnosis, screening, or patient monitoring. These areas are highly regulated because there's direct impact on patient safety. However, the areas of things like wellness, you're not ill, not yet ill, healthcare operations, training and education and research, they're more indirect, and therefore the regulatory controls are less, and there is greater flexibility in us developing tools to support the work. So, for example, let's take healthcare operations. But before I talk about that, let me also mention that in WHO's Mental Health Action Plan, there is an emphasis on integration, community-driven care, which is really on the right side of the house in this Venn diagram. So let me look at healthcare operations in eMHIC, which is one hospital, and this is happening across all our hospitals. We are developing what is called a technology adoption model, where we try to understand the changes that are needed and then empower our staff strategically, of course, to try and test. So, for example, in many of our departments, we have a lot of digital literacy training. Digital and data literacy, because sometimes assuming that digital literacy means digitizing and using digital tools, data literacy means that we now understand that the information that we key in and it's in the system, we're able to then disseminate. And we've done it in two ways: direct training, specific learning of tools, and also through competitions like datathons and hackathons, where we have an opportunity to share in a big group, look at ideas, brainstorm literally. And eMHIC has been involved in this. This is one example of AI related datathon. And I think all of this is leading to what WHO in the World Mental Health Report of 2022 talks about. There are three priorities: suicide prevention, child adolescent mental health, and mental health at work. And in terms of what a digital ecosystem would look like, there is a lot of shared governance, shared data and research, shared resources, and shared services in what in Singapore we term it as Smart Nation 2.0. But I think this transcends national borders and really extends to beyond national borders. For example, in the APAC Digital Hub, where the Asia Pacific countries are actually thinking about how we can have this shared model across countries. So now I'm going to hand you over to Chris, who will tell you more about our efforts in looking at a digital connector between our tiered care or step care model. Thank you very much.
Okay, thank you very much. I'll just start my presentation. Good morning or good afternoon, wherever you come from around the world. So my name is Chris. I'm a psychiatrist and a practicing clinician. I work in the Institute of Mental Health. Very quickly, I'm going to share with you what we have done at eMHIC on a very practical level. I see myself more as an implementer of services as opposed to research. And these are our efforts in our hospital. Some of the realities of the mental health problem in most industrialized countries is that there is a large number of people with mental health issues, but only a small percentage actually come forward to seek help. And if all of them came up to us face to face to seek help, I think all our services will be overwhelmed. And based on the clinical practice guidelines, if clinicians really do everything that the guidelines tell us to do, I think could only see maybe 5 patients a day. And really, beyond the clinic, little attention is paid to the things that go on between clinic sessions. So these are the realities of practice around the world. So digital mental health interventions can really intervene where a clinician cannot. And what we try to do is to not to really make the clinician feel threatened by technology, but we try to insert digital health interventions into the places where the clinician cannot reach. For implementer like myself, we through just by sheer I guess the last 10 years that I've been trying to do this, typically one of the biggest barriers to implementation is the clinicians themselves, because many of them are really quite afraid of technology. So for us to make it more palatable to our clinicians, we try to insert technology into areas where they don't really don't have any activities right now. So we try to provide CBT insomnia as an intervention. We try to have daily digital diaries for our patients so that they can chart their symptoms in between consultations. We would try to use digital interventions to improve patient education through YouTube videos, and then provide eCBT for those who would like to CBT, but then they are working. And of course, we use AI chatbots to sometimes assist clinicians to answer patients' questions on things administrative. So beyond just the clinical work, there are a lot of administrative questions regards to national insurance policies, as well as cost estimates. And lastly, to find services for them in the community, because I work in a hospital, but I need to find mental health services for my patients in the neighborhoods where they live. So I just quickly want to show you some of our efforts. So the first, on a broad national scale, we have implemented mynight.sg, as well as the National Call Center for Mental Health 1771. So we have digital self-help tools, self-assessment tools, as well as wayfinding tools to medical services. And we have subscribed to the WISA chatbot as well. Our call center can be accessed by phone call or by WhatsApp messaging. And what you don't see at the front end, which is just a simple phone call or WhatsApp, is that the call center, it is full of technology, everything from the CRM to our messaging systems, the automation, as well as the quality checkers, the surveys that we send out pre-call and post-call to rate our quality, as well as the data analytics to understand our users. So behind a very simple poster is actually a lot of technology, which I don't have time to go into that. But most of these technologies are bought from outsourced suppliers like Microsoft, as well as other suppliers. Our homemade front end, myline.sg, has a multitude of services. At the large level, we have our WISA chatbot, and we also have our service provider Intellect that provides all the mental health information for us. We have escalation pathways as well as simple CBT modules. And we also have digital peer support in the form of our Let's Talk platforms. All these are all anonymous, and we don't require anyone to give us a platform, an account. The platform has been very successful, and we have had 1.6 million visitors since 2020, with 53% of them engaging in some form of activity and 10 to 15% of them returning to us. For our Let's Talk platform, which is a peer support platform, we have more than 10,000 registered users with about 1,000 active users every day. And about 880 questions have been asked to our virtual therapists, for which we have answered them on the Let's Talk platform. Over at the hospital, we know that for us in Singapore, we have roughly a 2-month waiting time between the referral and the time we are able to see the patient. So right now, we are running a randomized control trial using this app called eMDTX, which is a mindfulness-based app as well as mental health interventions. In order to trial whether providing such an app during the wait list period can benefit our patients waiting to see a psychiatrist. It's halfway through, and I'll be finished with the trial next April. So after that, we'll do the evaluation. We have also invested in service finders, both for clinicians as well as self-help for our patients. So in this case, all they need to do is put in their postal codes and they'll be able to find general practitioners in their neighborhood as well as neighborhood counseling centers that have been funded by AIC to provide counseling services at their doorstep. I think I dare say that eMHIC has used AI in quite a big way, not so much in patient-facing operations, but actually to assist the clinicians in many of our activities. So one of the things that we did was that we used AI to write medical reports. So in my department in forensic psychiatry, we have to produce court reports, and we have used AI to assist us in writing the report, which saves us about 2 to 3 hours per report. And the beauty of AI is that there are no typos and no grammatical errors. There may be factual errors, but no typos and grammatical errors. And so this is really a big time saver for us. We have also created a multitude of training bots to train various workers, medical students, junior doctors, psychiatrists in training. So basically, we use the AI chatbot as a simulated patient. So we have bots that will help junior doctors diagnose psychiatric illness. We have bots that help residents learn how to do suicide risk assessment as well as forensic risk assessments. And lastly, we have a chatbot that helps the clinician quickly find services for our patients. So we have over 30 community services in Singapore, as well as more than 400 GPs willing to do mental health. So by quickly entering their postal code as well as the PHQ and GAD scores, we can quickly find services for our patients and direct them to those services. And one of the things that I'm glad we did was that even though it's not exactly e-mental health, but it's really e-like, is that we collaborated with our National Library to stock over 100 books in English as well as Mandarin on mental health issues. So our National Library was willing to stock all these titles for us, and they have been very heavily subscribed. Many of them are really, you can't even, it's always out on borrow. And this was a successful collaboration with our library. We have also implemented eCBT for mood and anxiety, and we are now we will start a national trial early next year to see whether it works for community-based patients. And of course, the good old teleconsult by Zoom for us. We have implemented it in nursing homes, into the court, into the prisons, as well as within the hospital. Yeah. So in summary, actually, at eMHIC, we really believe in digital mental health. What we need to do is educate all levels of staff in digital mental health. And so far, we have created more than 20 chatbots, AI bots to help clinicians do their work more efficiently. And we have a whole slew of digital initiatives which we've just started implementing only just about maybe 18 months ago, and we've gotten somewhere, and we hope to go further in the years to come. Thank you very much.
Thank you, Chris. Chris, right, you're up next.
Thank you very much. Hello, everybody. It's lovely to be here. It's Friday morning for me, so it's not too bad compared to some others on the call. I guess I'm just going to tell you a wee bit about what we've been doing in Scotland over what has been quite a long period of time. So we've been working with digital mental health since about 2002. And I've been working in the field since about 2002. So I was one of the first instigators of digital mental health in Scotland. We have an extensive digital mental health programme in Scotland, and a lot of things changed around about 2014. What we had up until 2014 was lots of regional activity around our digital mental health. And in 2014, through EU funding, we were able to focus our attention on creating a national structure, a national capability to coordinate our digital mental health activity. In 2018, we then received national funding from the Scottish Government to begin to implement our digital therapies programme. Our digital therapies programme is still ongoing and has been going for many, many years. But what we've been able to do over those years is really build a kind of structure, infrastructure, and a capability which focused on three key areas. So we focused on the development and delivery of digital services, fully integrated into our mental health structures, not our digital structures. We focused on evaluation of those services, and then we focused on cultural change, in particular clinical attitudes towards digital. So that was a program which we set up around about 2018, which has been responsible for the full development of our digital therapy services in Scotland. In Scotland, we currently have 37 different digital therapies covering a range of conditions and clinical populations. We work in the prisons, we work across young people, adults, as well as a whole range of different areas. Currently, we receive around about 72,000 referrals per year. That's a mixture of referral and self-referral. The importance of that is the same number roughly as our traditional psychology services. So what we're seeing in Scotland is parity between our digital therapeutic services and our traditional face-to-face therapy services. What we have is an extensive network of digital therapy teams across our 14 health boards or healthcare regions in Scotland. Each of those teams is responsible for providing access to our digital therapies, but also supporting the patients throughout their treatments. In 2021, we were able to establish a national digital mental health programme in the Scottish Government, with the remit being expanded beyond digital therapies to look at a whole range of different activities, including telepsychiatry and psychology, which we have an extensive service across the whole of Scotland, a whole range of different apps and self-management, as well as online support. In addition to that, we also looked at a wider infrastructure, which has been a really interesting journey in Scotland. So we started with innovation, looking at some of the key emerging technologies, such as AI, serious games, and extended reality or virtual reality. But what we also discovered is limitations. As we've progressed, as we've got a wee bit older, a wee bit more mature, we've come across a lot of limitations, particularly around things like marketplace purchasing and large-scale procurements. What we're doing now in Scotland is we're beginning to look at really what is a sustainable infrastructure longer term, what will give us the best opportunity to maximise digital while addressing the specific needs we have within the country. So we've started looking at a whole range of different platform techniques, such as no-code development of apps and digital therapeutics. We're looking at more innovative ways of introducing the kind of new and emerging technologies. And what we've become acutely aware of is the current structure is actually limiting our growth. So we're in a position now in Scotland where we've probably maximised what we could do in our digital therapy services, or maximising what we could do across our video-enabled therapy services. And actually what we're discovering is now that there's limitations to how far we can push this and progress, largely to do with budget limitations and the costs of procurement, but also actually the ambitions of clinicians and the services to want to do more with the digital. So there's been a real sea change in Scotland around a cultural acceptance of digital and a recognition that digital needs to be implemented and implemented well. There are areas in Scotland which I feel that we're lagging behind. I think Chris's presentation before really highlighted how you can use AI and other technologies to support the clinician to deliver and really enhance existing service delivery. The focus in Scotland has been primarily citizen-facing, so really developing large-scale digital services. So while we've made huge progress in Scotland, and I do think we're now at a position where digital mental health is genuinely mainstream, it's genuinely seen as something that we deliver on a kind of business-as-usual footing. What we're discovering now is that actually the structures that we're building need to be changed for the future and need to be changed for a long-term sustainable delivery of digital mental health in Scotland. That's me, Fiona.
Thanks so much, Chris. Really interesting. And finally, Holly.
Thank you, Fiona. I'll keep my introduction short so we can get into the discussion. But so thank you for inviting me to speak today. My role is very much focused on the regulation and evaluation of digital mental health technologies. So I work for the Medicines and Healthcare Products Regulator in the UK, so the eMHRA, and my role is as lead for the Wellcome funded project on the regulation and evaluation of these technologies. So we work in close collaboration with NICE, so the National Institute for Health and Care Excellence, who are the health technology appraisal organisation authority for England, and they also cover Wales as well. So we've been looking to clarify the regulations for digital mental health technologies that fall in scope of regulation, and essentially what that means is clarifying where the line is drawn between what a wellbeing technology is and also where a medical device technology starts to become in scope. So we've produced guidance, we've updated guidance around post-market surveillance for software as a medical device technologies, and we've also done a lot of work to try and understand the ecosystem and the landscape for how these products are used and how the public and healthcare professionals see them in terms of acceptability, their benefits, their risks, but also just kind of exploring the more broad considerations around how health technology appraisal and regulation can work more closely to make sure that when these technologies are evaluated, they're evaluated consistently and appropriate for how they're likely to be used in the real world deployment. So hopefully we'll talk a little bit more about that in the upcoming discussion, but just wanted to give you a bit of a flavour as to what work I'm leading.
Thanks, Holly. An absolute pro helping us get to the panel. So thank you. Before we jump into the discussion, just a quick reminder for our audience: please post your questions in the Q&A box, and I'll do my best to bring them into the conversation. I think we're very fortunate today to have three speakers from three different areas. And what I wanted to ask all three of you is that each of you approaches digital mental health from a slightly different perspective. We've heard from Holly in terms of regulation, we've heard from Chris in terms of real service delivery, and then Chris Wright from a sort of the perspective of national strategy. When you think about quality of care in a digital world, what does that actually mean in your context today? Or what is your most pressing priority in terms of digital mental health, whether that be for the patient, consumer, whether it be for healthcare professionals, or whether it be for the sustainability of our health systems overall? If I start with you, Chris Chuck, and then we'll take the rest of the panel as well.
I think for me, the most important segment is that needs our help is really to reach out to those people that don't wish to step forward for face-to-face help, because that forms really the majority of the people who are suffering. From Singapore statistics, we know that roughly 60% of people with major depression will not step forward. And of course, in the addictions world, more than 96 or 97% of people will not step forward. So I think that this is the group that will benefit most from digital interventions. The second area which we are interested to work in is the wait list, because I think in Singapore we have a 2-month wait list to see an adult service and a 6-month wait list to see a child and adolescent service. So we can't produce enough psychiatrists and psychologists, even if we did increase the intake, the time to train these people will be at least 10 years from now. So I think this is where another area where digital interventions can help out a lot. And these are the two areas of our work here in Singapore.
Thanks, Chris. And Chris, right, you talked a little bit about, you've obviously been doing this for a really, really long time. And so you're in a really good place to be able to talk about quality in terms of what you've seen from industry and how industry has been able to respond to your growing ambitions. And I just wondered whether you had any comments from that perspective in terms of industry keeping up with changing expectations.
I think it's really interesting. I think the quality question overall is really interesting, primarily because I think quality also drives acceptance across clinical and patient groups. So I think it's really, really important that whatever you do in digital mental health is focused on quality. and ultimately about the alignment of quality to what is a clinical standard and a clinical acceptable standard. And I think that's what's been really key in Scotland, is we didn't look at what is digitally acceptable, but actually what is clinically acceptable. And I think that becomes really, really important, that that is then articulated to industry. And I think what we see is lots of kind of organizations, industry, commercial organizations will be looking at what is the work that Holly's doing, for example, what's the work that's doing, around regulation, what's the kind of data requirements and so on and so forth. Actually, very little will look at what is a clinically accepted piece of technology. And clinically accepted piece of technology will be, well, how does it integrate into clinical service? How does it fit with your kind of service delivery models? Is it acceptable to most patient groups? Is it actually deliverable with the same level of clinical standard that you'd deliver face to face with? So I think it's really important that actually what industry is doing is they are looking at work that Holly and her organisation does and others do on a regular basis. They're preparing themselves for delivery in a healthcare setting, but they're also becoming very, very aware of what is a clinically accepted piece of technology. And I think what's really interesting with things like AI, for example, just now, it is not a clinically accepted piece of technology within mental health. And as a consequence, those that are delivering AI services will have to start thinking about, actually, how do we make this something that a clinician will trust? How do you make this something that a patient will trust moving forward? And I think that becomes about aligning it to what is already in place. What is the standard that people are already reaching within more traditional services, and then beginning to strive towards that moving forward. And I have to say that's the vast majority of my conversations with commercial entities will be about what is the evidence backing this, what is the patient safety protocols, what is the aspects of your technology which genuinely makes it safe and effective to use in clinical settings, not the kind of digital regulations that go with so many of the conversations with industry.
Thanks, Chris. And Holly, from a regulatory perspective, the work that you've been doing has been arguably in response to that gap and that need to evolve. I just wondered what your perspective is on it. And also from a regulatory perspective, where would you like to see this work go and this project that you're leading go next?
So it's interesting because actually some of the comments that Chris just made there are kind of the really key clarifications that are now the focus of the work that we're doing. So I think when we started this work in 2023, it was quite a different focus. Maybe AI was not the sort of hot topic of conversation. It was really to clarify kind of where that line in the sand between well-being and medical device. But what we've seen is this evolution of kind of the influx of technologies that are available that utilize AI, almost because of this kind of feeling of need to use it because it's there, and people use ChatGPT for all sorts of different reasons. But it goes back to that clinical acceptance, and actually, do patients and users and healthcare professionals want AI to essentially replace clinical tasks that are fundamentally therapeutic in nature? So where you are looking at replicating empathy, where you're looking at replicating the ability to interpret body language, those are really, really highly advanced skills that it takes a long time for humans to be able to become adept in. And actually, it's that acceptability and looking at how advancements in this area can actually be enhanced in the ways that are actually going to help healthcare professionals and patients live with their symptoms and live and to use these technologies in a more appropriate way. I don't think I've articulated that very well, but I think there's been this surge of kind of, we need to use AI, but now we're kind of reining back in and going, well, how can we use it in the most appropriate way? So if that's looking at, okay, we're not going to use it as necessarily a tool that will speak to a patient directly, but can we use it to, support the administrative burden of clinicians that are wanting to transcribe and summarize their interactions with patients, for example, and making sure that that tool is then, validated through evidence generation and trials, but also then follows the regulatory framework to make sure it's safe and effective and is consistently evaluated through its deployment. So I think we just evolve quite quickly through where the focus is, and I think that's what we want to do as a regulator, is make sure that we are aware of how these products and technologies are being used, what their acceptability is in practice, but also making sure that we ensure regulations are agile and that we're responding to the different needs of users, but making sure that all the products that are coming to market are safe and effective. So hopefully that answers your question, Fiona. I feel like I've navigated through that in a very weird way, but yeah, hopefully I've responded.
No, I think what I heard was that there is a nuance to clinical practice that that means from a clinical acceptability perspective, there are bigger questions about the extent to which AI can really genuinely operate in this space. And I think that's one of the to play it back. But I think also, as you say, as you were talking and thinking about sort of, certainly Gen AI particularly, that there has been this need and exposed this need for a certain agility when it comes to the regulatory perspective. I just want to keep on this topic of clinical acceptance though, because I think it's so important when we think about the use of technologies, when we think about how healthcare systems are investing in these technologies and making sure that they are being recommended where they're being procured by systems, that patients are using them, and that it doesn't remain. I still wonder and I still question the extent to which we all know that you can use an app and you might use an app 2 or 3 to 4 times and you may never look at it again. So I'm always really curious as to how you maintain that clinical acceptability after you've made the decision to implement a technology. And Chris, I just wonder whether you had any thoughts about that in terms of, you've made the decision to use a particular technology, whether it's a Wiser in Singapore or whether it's a different technology in Scotland. How do you maintain that professional buy-in and that acceptability on an ongoing but also a long-term basis to ensure that this really is sustainable? And both of you seem to be really well placed to answer that question because of your successes in this area. Chris, right, I'll go to you first, if that's okay, and then we'll go to Chris Chook.
Again, really interesting question. I think there's probably 2 or 3 parts to this. I think you have to get your implementation strategy, right. I think you have to focus on the right things during that implementation process, and a lot of that's about education, dissemination of evidence, making sure that there's a kind of understanding of the technology across the clinical setting. I then think you have to have consistency of the approach. Implementation and particularly adoption isn't something that just happens. And adoption is a long-term change. So you have to think about your change management processes and various other things. I think the last thing and most important thing is the outcome of that, which is genuine integration. And actually, how do you integrate the technologies into clinical delivery and into the kind of wider health and care system? And I think everything around implementation, any marketing strategy, promotion strategy you have has to lead to full integration. And if you achieve integration, then what you do is you achieve sustainability of delivery and sustainability of adoption. So you need to be thinking from the outset is actually, how do I integrate this technology into the clinical settings? And that will be integrating it into referral pathways, integrating it into all the different clinical delivery strategies, integrating it into all the various different aspects of day-to-day delivery that happens in all our psychiatry, psychology, and community mental health teams, for example. And that's really got to be the outcome. So what I'd be suggesting is when you're thinking about long-term adoption, you have to think about, well, what is the kind of long-term strategy around about this? You implement the service, but you maintain a focus on adoption for a long period of time. Bolster that with strong evidence, dissemination of information, build a very clear understanding across clinical populations as to what this technology does. But then what you're doing is genuinely focusing on how do you integrate this technology into standards, business as usual clinical delivery.
Really, really interesting and really helpful. And I think what you've just said really exposes the challenges that we exist in a healthcare system today that is very much thinking about in year, short term, what can we do, quick fixes, and how that bangs up against the need, actually, if we're really going to yield the benefits of digital mental health, AI, all of these different things, that actually it does require a long-term strategy that focuses as much on those long-term gains as well as sort of those in-year necessities. Holly, I just want to turn to you, and we'll hopefully be able to revisit this conversation again. But in our discussions, you've really been quite you know, you've warned against this kind of getting swept up in this Gen AI wave when we haven't yet standardized the basics. From the MHRA's perspective, what are the biggest gaps that we still need to close to ensure confidence and safety in digital mental health tools? And what are your key priorities in that perspective?
So I believe that there's still a lot of work to do around educating developers and industry around regulation in the first instance. So actually recognizing when a product qualifies as a medical device and what your obligations are as a developer of that technology to come into scope with a regulation, understand the classification within which you fall, so the risk class, and what you need to be doing. But actually there's an earlier piece of work there around the development of these technologies and actually, you know, funding applications that maybe don't always consider the regulatory pathway and perhaps cost that in as part of the funding application, because regulation can cost a lot of money. It can be something that could be cost heavy, but actually building that in early makes sure that you are very aware that you are potentially developing a medical device and that the costs are there to ensure that the resources are put into making sure that those products are safe and effective and evaluated consistently. So there are reasons why regulations exist, and it is ultimately to ensure patient safety. But it's really important that the whole ecosystem understands that and that regulation isn't a barrier to innovation, it's there to support it. So I think in the first instance, it's very much about being aware of regulation, what it serves to do, and then the ongoing obligations around post-market surveillance. And actually that's everybody's role. That's not just the developer in terms of what their post-market surveillance strategy looks like and reporting adverse events, but it's equipping healthcare professionals and users of technologies to understand actually what does a harm event look like with the use of these technologies. And that's a really difficult thing to define. It's quite an ambiguous sort of subject, but what we're doing is being able to try and really pin that down. And actually we're hoping by the end of the year to launch e-learning materials that will equip users of these technologies, healthcare professionals that may recommend them, that are maybe using them in their practice, but also patients in the public to understand what a digital mental health technology even is, recognizing the difference between a wellbeing product and a medical device, and actually understanding again what those adverse events look like and how to report them, because reporting something is really important with its constant evaluation. So I think really just understanding the life cycle of the technology, how they're developed, the regulatory obligations that come along with that, and then its ongoing evaluation to, again, look at acceptability in practice, because we're talking about the same thing here. We're just looking at it from a regulatory perspective, but it is all about contributing to that acceptability. And actually, is the product doing what it says it does? And is it creating the benefit that it was hoped to in the first instance? So all of that ties in very much with the regulatory framework. So we hope that we're making sense of that through the project work that I'm leading.
Really helpful. And Chris, do you have anything to add to that from a sort of a, because I think there is that regulatory side, but then there's that practical delivery side, and then thinking about, well, what does that mean on the ground, either for a patient who may have had an adverse event using a technology and their understanding of what is an adverse event when you're using a technology. And I just wonder whether you've got any insights into sort of those sort of issues that Holly identified in the context of service delivery.
I think again, it's really interesting when you consider what regulation's role is within digital mental health. I think there's a general attitude, I guess, across a lot of industry in particular, that the regulation's too hard, too difficult to kind of go through. But what the regulation does is it gives a level of assurance and reassurance to healthcare providers ultimately, and that's what this is all about. If you want your technology to operate within a healthcare system, to operate across patient groups and various other things, we have to have confidence in it ultimately, and that's what the regulation does. It gives us confidence, both in terms of things like data protection, internet security, the kind of medical device regulations, for example. It's really, really fundamental to how we purchase as much as anything. And I think Holly's absolutely right. I think that there's a kind of sense that sometimes that we surprise industry around about the regulation, when actually the reality is it's easy to learn about these things. There is a cost associated with it, but there are huge rewards at the end of that process. And I think we begin to see that now with large national contracts beginning to become a reality across many, many countries. And I think that's really, really key. I think what's really interesting is, if you're looking at GPs using medication or looking at, psychiatrists using medication, they have confidence in that drug or whatever it would be simply because of the regulation. So I guess that's the first point I'd make. I think what's really interesting is what is an adverse event within digital, and then what is the scale of impact of that adverse event. So I don't think we really know what adverse events are, and I think, for example, we know now that social media can be very damaging towards young people in particular, but we also know it can be very beneficial. And there's just not enough evidence to kind of say, well, what are the benefits and how do you mitigate those risks? We know that there are risks around about things like suicidality or self-harm within digital, in the sense that things are remote. But I know from my work in Scotland is you can mitigate those by having systems which can build in good kind of risk mitigation systems, the ability to communicate well and integrate well with kind of local clinical services or emergency response services, for example, can be done, but they're not considered enough as being a priority within a lot of the technologies that we see in Scotland. So it's actually how do you genuinely create patient safety as a core activity within these services, I think. And I think what's really interesting is ultimately there's a slight overreaction, and this might be a wee bit controversial, because what we tend to find is if there's an adverse event in digital, it impacts all digital. So every digital service we offer is effectively impacted. There are adverse events happen all the time in mental health. It's just the nature of mental health, and we have systems in place to address that, and systems that we have in place to ensure that whatever the incident is then is minimized as much as possible. What you tend to find in digital is we have those systems in place if it's well designed and it's a good service integrated into clinical settings. But if there's an adverse event, the reputational risk to digital is huge, absolutely. So as a consequence, what you tend to find is people shy away from digital simply because of that potential of an adverse event. And actually, the reality is adverse events happen all the time in healthcare. We have ways of addressing it. And as a consequence, we have to take the same approach to digital. Things will happen, unfortunately. And actually what we have to do as healthcare structures, as service delivery, is to ensure actually that we minimize what the impact is of that incident to the person at the core, which is the patient. But we also then work to understand why that happened and make the changes as you would with any clinical service.
It's really interesting from a couple of different lenses. I think from a safety perspective, to your point, there's always a lot of chat, I think, especially sort of saying, oh, well, there was this one adverse event, but actually it's the trade-off that for the 95% that wasn't adverse, and kind of how you make sure that your reactions are proportionate to the effect and the impact. As I said, I'm going to turn to the audience's questions and I'll liaise with Chris. One of the questions has been, what's the scope of telepsychiatry worldwide? So I guess, Holly, I know that you've been doing a lot of travel all over the world to talk about what the MHRA is doing. And Chris, obviously, with your deep and breadth of experience in this field, I just wondered if you were able to have any response to that question.
I'm happy to go first, but telepsychiatry quite often falls outside of the remit of regulation, and the reason being is that it's the regulation is of the interaction between the therapist and the individual, unless obviously that's being purported as an AI agent, or there is a software or AI component that triages the need for that in the first instance. So I actually don't have a very good grasp on the global sort of availability of telepsychiatry. I know obviously it's becoming much more and more widely known. So Chris might be able to answer this question better, but unfortunately, it does tend to fall outside of our scope of regulation. Sorry, Chris, I feel like I'm dropping that one on you.
Right, I don't mind. I think actually the potential is massive. I'm really excited by anything kind of telepsychiatry, telepsychology, primarily because of the reduction of inequality, ultimately. And in Scotland, for example, we We have a very well-formed teleservice, video-enabled therapy services, we call them in Scotland. But what we're actually doing now is we're beginning to create kind of cross-region group therapies, for example. So in Scotland, we have 14 regional health boards. We have a very large health board in Glasgow, a very large health board around Edinburgh. But then as you progress up further north, you have very small, very remote, very rural communities who have their own services. As a consequence of what you tend to find is the service that you receive in Glasgow will be very, very different from the service you receive in our Orkney health board, for example. What we're finding is we can begin to break down those inequalities and limited access to service through telepsychiatry and telepsychology services. We're also very aware that we have clinicians working in NHS England who are also supporting service delivery in NHS Scotland. So what you tend to find is this ability for things like telepsychiatry to begin to break down a lot of the kind of barriers we have around geography, lots of the barriers we have around kind of rural communities, as well as the kind of spread of speciality across a lot of our services. There's lots of specialists in different parts of our country, for example, but depending where you are, you may not access those specialties. So what we're finding is telepsychiatry, telepsychology allows us to get the people with the expertise to connect with patients who need that expertise. So if you extend that beyond the UK, for example, you can imagine that this becomes something which can be much more universal, and you can find telepsychiatry services and telepsychology services working across lots of different regions and countries, as opposed to just within the kind of boundaries of one country. So I think there's lots of opportunity. But what you'll find is the work that Holly does around regulation and the need to standardize a lot of our approaches would have to be there. There's also pitfalls around kind of cultural acceptance and cultural context around about delivery, and making sure that you don't just chuck in a psychologist from Scotland into some other country and hope that they can do a job ultimately. So there'll be lots of requirements round about developing consistency, making sure that the appropriate context is placed on the treatment that you're providing. Actually, if you look at the evolution of technology, particularly around the delivery of kind of telepsychiatry, there are lots of opportunities, but it requires quite a lot of work to organize it. That's what I would say.
Yeah, it's really interesting what you're saying, because I think aside from the sort of the regulatory piece, you're quite right, thinking about the professional regulation and registration as well, and how that transcends geographical barriers, but also the huge upside, particularly for Global South, where there's shortages, and thinking about kind of rural and isolated populations. I think you're right to sort of highlight and flag the promise of it. Two more questions from the audience. I'm just going to stick with the regulatory perspective first. Holly, how does the UK regulate and assess safety of self-help apps so that patients and users do not download unsafe apps?
So again, it depends whether or not that product falls in scope of regulation in the first place. So we have medical device regulations that are the framework for what a manufacturer has to work within, and for a device to qualify as a medical device, it has to have a medical purpose and sufficient functionality. So complex enough functionality over and above just replication of perhaps text as a digital version of it, or some level of interactivity. It's not just a digital version of a self-help book, for example, because we can't regulate books and we wouldn't regulate kind of content as such in that way. So that would mean that probably quite a lot of self-help apps may fall out of scope of regulation and are more well-being products, even though they have a potentially a medical purpose. But what we're actually doing is, aside from the regulations being a really strong framework of assessment, and actually assessment for class 1 products it's self-certification, and for a class 2A product and above, there are independent assessments that are undertaken by approved or notified bodies, depending on the availability of the product in Great Britain or Northern Ireland, to be able to then assess conformity with the medical device regulations. But what we are doing, sorry, I'm aware of time, is that we're developing an evidence generation standard in collaboration with BSI, so the British Standards Institute. And this is designed to be able to provide any developer, whether you're developing a technology that's in scope of regulation or not, so software as a medical device or a wellbeing product, in how you generate your evidence for the app that you're developing. So it actually provides a really good framework to be able to provide really high quality evidence of trials, and actually be able to present that information to users of technology to demonstrate that your app does what it says it does, and with the population that it's intended to be used by. So that is the kind of work that we're wanting to be able to set an exemplar, in that users can then assess themselves whether or not the product looks like it's been developed in collaboration with lived experience with users of these technologies, and with a high quality trial that demonstrates that it's acceptable and safe in the first instance.
Thanks, Holly. I am conscious of time, but I just did want to ask both Chris's this question from Nina. Hello, Nina. Are you seeing any differences in acceptability and use between younger adolescents and older adult patients?
I think on our side, I think the younger people are definitely more happy to do text messaging, as well as use new tools and engage the internet for help. But once they come into the internet and find help, the feedback that they give to us is that they really want to connect with a human being. So even though we did give them a digital option, what we see on our peer support and all that is that they really want to step forward to actually meet somebody, because in Singapore at least we are a very digital society, on our side.
Great. And Chris, I've seen you present some really interesting information about this in the different age groups. So I just wanted to see what your thoughts and comments were.
I think it's a really, really interesting point, because I think there's a kind of general sense that younger people engage with technology more happily or more readily than older people. We have evidence to show that actually older people, particularly older adults, 75 plus, are more than happy to engage with digital if they have a wee bit of support around about them. So if they feel that digital is a wee bit overwhelming, if you put a wee bit of support in, they're really happy to engage with it, and actually the outcomes are fantastic. So the engagement levels are higher, the kind of completion rates are higher. Everything's really, really good. So we tend to encourage our referrers to refer older adults a lot, because it makes our stats look a lot better. Younger people are much happier to pick up a device, but actually what you'll tend to find is there are a lot more scrutiny around the technology that you're using. So we have, again, evidence to show that, we can get young people into our services, but if the technology is not right, or if it's not engaging, or if it doesn't do what they want it to do, they'll disengage very quickly. So there's a level of acceptance to start a digital treatment or engage with digital, but actually then the dropout rate might be a lot higher because the technology might not do what they wanted to do. Whereas what you'll tend to find is if you can get older people into their services, actually the reality is they do very, very well, but you probably have to support them. But they're a lot more accepting of the digital that you're offering them. So it is a really, really interesting question. And I'm sure there's about 50 research papers out there that people could start just on this topic alone. But certainly our experience is you can get people to engage at any age, as long as the foundations and the structures are correct.
Amazing. Thank you so much, Chris. And I think that's a perfect way to bring the webinar to a close. So as we wrap up today's session, I want to extend a huge thank you to our panelists, Dr. Daniel Fung, who couldn't join us for the live panel, but obviously presented his an interesting view of the work being done in Singapore, Chris Chook, Chris Wright, and Holly for sharing such thoughtful and inspiring perspectives. And I'm sorry about your connectivity, Chris. You'll just have to come back again soon. And to all of you in our audience, thank you for being part of this really important global conversation. Your engagement and curiosity are what drive this movement forward, and we hope you'll continue to support eMHIC's mission to transform mental health care through collaboration and innovation. And this is where I get into my TV presenter slot, which is a quick reminder that the eMHIC Congress 2025 is coming up on the 19th to the 21st of November at the Western Harbour Castle in Toronto, Canada, with online access available for those joining remotely. It's an incredible opportunity to connect with leaders from over 40 countries, explore cutting-edge digital mental health solutions, and contribute to shaping global frameworks for mental health equity. We'll share a registration link in the chat if you'd like to learn more. And once again, thank you for joining us. We do have another webinar next week, but on behalf of the eMHIC team and ahead of the weekend, I wish you a wonderful rest of your day or evening, wherever you are in the world. Thank you very, very much.